Hello, everyone. Welcome to April 22nd. Looking back, we should have done something on April 20th, but maybe next year. So here we are with Dr. David Dodson. We're going to learn a lot about Minnesota's program, what he does as a pain physician, and really, I think, the most influential cannabis physician we have in Minnesota. So with that, would you mind introducing yourself and kind of what you do?
I'm Dr. David Dodson. I have a clinic here in Robbinsdale, Minnesota. I'm here with my wife, Jennifer Tresnant. She's also a medical doctor. So together we started this clinic, and our background is family medicine. And we were fortunate enough to meet Mr. Eric Dale. He's our clinical director and also mental health counselor. And so we're providing a lot of services. Our background is family medicine. We're helping with pain management, addiction medicine. For 4 years, I was the medical director for Specialized Treatment Services, a methadone clinic in 4 cities around the Twin City area. And we gravitated around 2015 to medical cannabis and had the pleasure to meet Dr. Kane. And she helped us, kind of gave us a wonderful insight to all the medical virtues of medical cannabis, the wide medical safe virtues. We've just been totally overwhelmed and surprised, and we love the medical cannabis. All of our patients do as well. We've treated babies as young as 6 months for brain cancer. We've treated the elderly for seizures. We've treated the young people coming back from the Iraqi war for post-traumatic stress disorder. There's new applications, every year they're about, for new applications for medical cannabis. It's so versatile and yet so safe. Think of the opioid use disorder, how dangerous it is, how the tens of thousands of people have died just trying to get relief from their pain. That, in addition to other medications like the benzodiazepines. These medications are very dangerous. Benzodiazepines are one of 3 medications in the world where you can die from having oversedation and die from going into withdrawal, the other 2 being barbiturates and alcohol. So by no means are the current medications for pain and pain-related anxiety safe. It's so wonderful to have a substitute medication like medical cannabis. It's able to provide just a myriad of medical virtues and is so safe. No one has ever overdosed on it. There are no drug interactions. It's wonderful. We can be more assertive with the medication and take greater steps and not have to feel like we're walking through a minefield every time we're trying to stabilize a patient. So what was great, Dr. Kane has been very open and very approachable in the years. So I would like our discussion to be very informal but very informative. And so I would like to turn this over to Dr. Melani Kane. She's the PharmD president of PrepCan and the executive director of the American Society of Cannabis Pharmacists.
I'm so grateful that you were able to spare this time and really share with us, because the integral healthcare team is so important. And I think especially with cannabis here in Minnesota, where the doctors diagnose and certify the medical condition and ensure that there's some type of follow-up monitoring going on, and pharmacists dispense and dose. And how has that been different for you, I guess is the term I'll use? I know it's kind of off the cuff question.
Usually doctors prescribe and pharmacists fill. Now doctors certify and pharmacists prescribe. So I think this is wonderful that this is brought over, to the pharmacist to be able to, provide these prescriptions. At the same time, I think there's some legal wrangling that kind of keeps the doctor out of harm's way. And I am sure that on a federal level, we may not be totally protected, from the Fed, but protected by the state. So what you don't want is 50 men with machine guns and flak jackets running in here at any time, which is crazy.
I tend to avoid the acronyms.
Exactly.
That's my advice here.
It's a wonderful medication, and it's a wonderful thing to have an extra tool in your tool bag to be able to treat pain-related anxiety.
Yeah.
Many of the issues that will substitute the current dangerous medications like the opioids, benzos, soma, and other sedatives that can so often cause oversedation and addiction.
Going back to kind of the role of the pharmacist, I think the biggest disadvantage we have right now is, when we start a CBD product, for example, and we know it might have some change on the other concentrations of seizure drugs, but we can't order labs. So I think the inability to be seen as providers where we can, bill for our time and things like that, it's probably why our state is a little bit more expensive compared to other states when you look at their product prices. But I am glad that we have the quality, and you kind of talked about it, but we're so used to pharmaceutically available products that are consistent 100% of the time because they have policies in place. Whereas different cannabis manufacturers, different dispensaries, different growers, whatever it may be, we can see those changes, and it can be impactful. When you have a patient that's stabilized and then they have a new batch and then they're not, that can be very challenging. Have you had patients come to you and try to ask, like, hey, this cannabis isn't working for me? Do you encourage them to revisit their dose, or like, when do you give up?
Yes, never do I give up. I always tell them, I really encourage them to go back to the pharmacist. The wonderful thing about the THC and the CBD, they have the entourage or synergistic effect, where the two together are better than the individual, cannabinoid.
Absolutely.
So if they could just get the right percentage of the CBD and THC, I always encourage the patients, be the squeaky wheel, be your best advocate, keep going back, keep asking the pharmacist to get the right percentage just for you. It's working for my pain, but not necessarily for my spasms. It's helping with my sleep, but not my digestion. So keep working with it. They'll get the percentage exactly right for you. And each patient has a different physiology, or each patient may have a different drug interaction with other medications that they're on. Polypharmacy is one of the biggest challenges that we deal with, in addition to, over-sedation dangers and things like that. But the answer is always go back to the pharmacist to improve and see if they can get the percentage of the CBD and THC perfect.
And I'll say, I am always relying on you, you specifically, but you as a physician, to manage the other medicines as well. You can't just forget about the other slew of polypharmacy that patients might be on.
Yeah.
How do you find challenging / rewarding of helping people titrate their other doses, whether it's opiates or benzos or even non-prescription pain medicines?
Yes, we have many challenges. One of the challenges we have is that we oftentimes have referrals from other doctors. We recently had over 1,000 patients refer to the clinic. Some of these patients had been treated by the previous doctor since 1962, before I was born. So they were absolutely, yeah, they had cars back then. Anyway, it was very difficult to have these patients come into our clinic, and for me to try to tell them, they're like, well, Dr. So-and-so always did this. They were used to higher and higher levels of narcotics. Back then, pain was the fifth vital sign. It was intolerable. You could actually, get in trouble through legal means if you did not keep the patient's pain under control. This was back in the 80s and 90s when high levels of narcotics did increase. Now things have changed since then. We've learned a lot more. So now these patients are here, and I'm trying to teach them about what opioids do over time. One of the things that we deal with is, as opioid medication had increased, there's a condition known as hyperalgesia or aldynia, where the pain threshold actually goes down as the narcotics go up. I'm working currently with a bunch of physicians at Hennepin County Medical Center in their ECHO program, and we're actually finding that we can actually reduce and reverse the hyperalgesia and aldynia by reducing the narcotics by about 10% per month. And then the pain threshold goes back up, they become less sensitive, and then the pain levels drop. Now, that's a very tough sell for a patient who's been on medications for over 50 years or 30 years, or but it is working, and it is changing. We've lost none of those patients. None of them have overdosed, and we're doing wonderful things. So I get the advantage of working with other doctors in the community, and that's what I think medicine is going towards. It's no longer just the doctor by himself, kind of the Lone Ranger. He or she really needs to work with other doctors, other physicians, pharmacists, other medical professionals who have been in these areas of medicine and know and can help. So huge advantages there. Great advantages of being able to get the patients off the opioids. Sometimes when the patients are on opioids, their entire self is arrested at that time. Say they start opioids around age 18. oftentimes you'll see many of their emotions are arrested around age 18, and they can't really deal with a lot of the emotions. As we bring the narcotics down, now they wake up and they have to feel again. Many of them, are surprised they can taste things better. They can feel better. They have better relations with their wives.
Now, is that just decreasing the opiates, or is that adding cannabis?
That's decreasing the opioids, but adding cannabis as well.
Okay, because it does affect taste.
Exactly. So what's wonderful is now we have a wonderful substitute for pain management. And the patients are finding that medical cannabis is wonderfully applicable to their pain management, to their insomnia, to the muscle spasms. And now we finally have a tool in our toolbox to give to these patients when we take away their opioids, and I'm just so excited because there really is an answer to the opioid crisis, and that's medical cannabis. Now we finally can reach out to these patients and actually show real change.
Absolutely. I know that Minnesota requires the patient self-evaluations, which, if you're not familiar, it's a survey that you have to take before you get cannabis, and then each time you pick it up, so that we can kind of track what's going on in terms of your pain, your anxiety, what have you. Do you ever read them? Do you ever read your patient self-evaluations?
Yes, I do, and they're very enlightening. I think sometimes a good critique is your best friend. I think Serena Williams does not like to be coached on her serve, but when she improves. And so if we treat that as a way to improve and to get closer to our patients and to be able to, have a better relationship, a better covenant between the patient and the doctor, I think that always helps. And patients understand if say you got something not quite right the first time. There's a great expression in medicine, it's never too late to get it right. And so I think that's the case with medical cannabis. Now we're finally onto the right medication, but very much so we do love critiques. Yes.
I will say it's challenging when a lot of the medical community sees this as like a last line resort. Like, okay, we've exhausted everything for this child's autism. We've tried antidepressants, we've tried antipsychotics, gave them diabetes and high blood pressure, and now we'll try cannabis. It's like, okay, maybe we do need to revisit its place in the industry and in healthcare. I also want to ask you, do you find any types of pain in particular respond better to cannabis?
All types of pain, migraine headaches, complex regional pain syndrome, which is one of the most challenging.
Yeah.
Complex regional pain syndrome, previously known as reflex sympathetic dystrophy or pain, has been a very challenging disease and illness. It's typified by, say, a man hits himself in the hand with a hammer and has inflammation. There are soft tissue and even bone changes, and atrophy of the muscle and tissues to that hand. And it may not only be relegated to one hand, then it takes effect in other limbs, which is just astounding. You're like, how is that even possible? How is it possible for the thought, a suggestion of pain, to then take on a physical manifestation? It's poorly understood, but we see now that there's a wonderful connection between the mind and the body, an interface that we haven't quite understood. Medical cannabis has a way of getting in between that interface. A wonderful way is through post-traumatic stress disorder. Usually the limbic system is designed to protect the body from danger, and it has a positive feedback to remind yourself. If you've ever been stung by a bee, the next time you see a bee, you're going to have a strong emotional response. With post-traumatic stress patients, now that feedback response interferes with their functionality and their quality of life. Medical cannabis has a way of getting involved, getting in between that interface and dampening down that feedback. And it's amazing. But some of the other challenges that we have is just chronic pain itself. Chronic pain can be a huge anxiety producer.
Mm-hmm.
Anyone that has to live with pain 24/7 knows that there's no greater trigger than having all of their anxiety exacerbated through chronic pain. It interferes with your sleep and so many other things. So just regular chronic pain is a challenge, and other forms like that.
Absolutely. Do you find that most of your patients know about cannabis and they bring it up to you, or vice versa?
Some of the elderly patients have been raised the way I did. I was raised back in the 60s, and, you know, we tried cannabis, you know, but back then we got a lot
When
of
it was like 1%
exactly,
THC.
yeah, the indica 1% THC, the sativa and the hemp, you know, the CBD, not so much, you know. And so there's kind of mixed feelings, say, with the elderly and with the people of my age, you know, in the 60s and age 60 or thereabout. The younger people are more hip to the medical virtues of medical cannabis. You know, they know of it. They're much better educated on some levels.
Yeah.
Although my nieces and nephews will sit side by side and talk to each other on their cell phone and not raise their head. So I'm fearful they're going to lose, you know, the musculature of their necks, you know. But
That's true.
young people are actually very informed. I'm having to re-educate the elderly, though, and middle age to the medical virtues, because there was so much to unlearn. There is so much to unlearn about cannabis. Cannabis was called marijuana, so as to take on a Latino name and for it to sound like something moving into America, I think at one time, you know. Don't you agree?
Definitely racial.
Yeah, so
Racial
there was
undertones.
a racial, you know, attack and something.
I think it's because I did some research on it. I think it's because before like the 1920s, like we use cannabis as medicine and we use it as extracts in oils and alcohol, and we used it like orally and stuff. Yeah. And then when Hispanics came over in like the early 1920s, they were smoking it, and that was like blowing the mind of the Americans at the time. And they kind of try to associate it with that subset. Mm-hmm. And think about it, you know, from a pharmacological perspective, you're avoiding the gut, you're having immediate absorption. Yeah. You know, the effects are very easily pronounced and quick. And I think people saw that immediate change and were fearful. Whereas like, I think a lot of what we talk about with pain is, you know, not just the placebo effect, but the nocebo effect. So, you know, definitely low dose, it's biphasic, low doses are preferred, but you never know what you're getting with the flower. So do you have any personal, stop recording if you want. Well, I just asked because, you know, a lot of, like in the pharmacy, I really appreciate having controlled, consistent doses in pharmaceutical forms. I've got pills, I've got liquids that we dose with milliliters, I've got mouth sprays that you spray. Like it's very intuitive for patients to take it. Whereas if I gave them a flower, they'd be like, what is this? Yeah. I don't even know how to make tea from it, you know? Right. So, but it would lower cost. So it's kind of that, you know, help patients make their own medicine and figure it out, or give it to them, control it. You know exactly what's going into it.
Yes.
What do you think?
I think the elephant in the room is big pharma. The people that make the opioids and other pain medications want to keep medical cannabis on the Schedule I illegal list, along with methamphetamine and cocaine. And it's so sad. First of all, it's so very hypocritical. Opioids have killed more people, tens of thousands of people, and medical cannabis is completely safe, and no one has ever overdosed on it. Question, will we ever be able to get the edibles like California or Colorado? I would certainly hope so, and I would be 100% for it. I think that Big Pharma still has deep pockets and deep political ties, and so that's going to be a fight. And Minnesota, I think, is conservative on many levels, but I would be all for the edibles and to push legalization
for sure
as soon as possible.
Yeah, I think about 80. I just throw this number out there, no actual evidence here, but I throw that 80% of the patients I see, they don't need me after the first visit because they've figured it out. They've found what works. Yes. They know what the effect is going to have, and they know when they can use that. So it really is teaching our patients to self-manage their symptoms or self-medicate. And that's why I think the self-evaluations that are required are nice, because they force patients to kind of take a moment and say, and reflect and say, okay, yeah, this is making me a little bit more anxious, you know, and they might not realize it's the medicine, but as healthcare professionals, we have to go through and say, okay, is this the cannabis? Is this your cancer? Is this the other slew of medicines you're taking? You know, did you just have a bad sleep? You know, symptoms fluctuate, and we can't always be there for patients to say, all right, we got to do this. You know, we're about to get chemo-induced nausea and vomiting. Like, let's take a puff. Like, we don't have that comfort of doing so. Anything else you wanted to talk about?
You know, mental health is a huge need right now. And I would like to introduce Eric Dale, our counselor and clinical director. Eric, do you want to say a word?
Sure.
Or,
Oh, yeah. I mean, can you hear me from there?
I think so. Let me hear you again.
all right.
Yeah, well, what would you like me to talk about?
Just in general about what you think mental health and how it can be improved with medical cannabis, or what are your thoughts?
So I think a few things that you guys touched on. Also, I think the pharmacists are very well educated on dosages, applications, things like that. So that's been interesting to see, because I think as savvy as our generation might be, I think they're still working on like what's the high school equivalent. So I think you guys have to work to educate the patients, because they're coming in thinking, hey, now it's legal, now I can kind of have carte blanche with the flowers, with this, with that. I think part of it comes down to the education that you guys provide, which has been really good. So that's my first note on the program. Mental health wise, I think you always are going to have polysubstance abusers, no matter if what's legal and what's not. I think the more that cannabis gets pushed to not be a Schedule 1, because the recreational usage is so high, I think that you'll probably see more of the people start dropping off of the others, because people will be able to supplement. As much as people like to think it's a gateway, it's usually more so an easy stepping stone for people who already want to use more strongly. That's what I've seen clinically for years.
I think alcohol is the real gateway.
Yeah.
Lowers your inhibitions.
I would agree. I think that's usually you have depressed people who are drowning themselves in depressants, right? So yeah, the alcohol is a huge variable. As far as any negatives, cannabis, the only ones I'd ever see when I was at the U of M on the inpatient wards were, psychosis.
Yeah.
For schizophrenics.
It's
or young,
real. Yeah.
Oftentimes it was the most common was young Black teen females that didn't know they were at that cusp of being diagnosed. Mm-hmm. So this was kind of their sentinel event that triggered them, and 3 months would go by. They'd use again, they'd end up back there. They're just trying to be normal, but those are those screening things. So we've implemented a schizophrenia test. It's called a STEP test here, so that we can just screen out everybody, because having 1 or 2 negatives is what's going to make the news, not the tens of thousands of positives.
Absolutely. No, it's unfortunate. I think there's been some studies, well, and really with schizophrenia, I think the evidence shows that cannabis can increase or decrease the age of onset, but not necessarily like give it to you. So if you were going to get it, you're going to get it, but this might shorten that amount of time. So, there's some studies that compare CBD as like an antipsychotic. So potentially it would have some benefit. Bipolar, they do see that as a potential deficiency state where something's off. And, sometimes people will use cannabis and they seem like very, very manic. Mm-hmm. And, that to them, they might be that way without cannabis. So it's important we always look at each patient individually. I want to ask, does anyone in the audience have any questions? No pressure. Yeah.
I guess this might be a little off topic, but what is your opinion on kratom on pain management?
Kratom is a stimulant. It can be dangerous. All stimulants, if not controlled through pharmaceutical oversight, can be, I think can be dangerous. I think that it's not quite on the illegal list. When I was at the SDS Specialized Treatment Services, some patients would come in under the influence of this stimulant, and that people wouldn't know really what it was. It wouldn't show up on our urine drug screens. But I would like to make sure that is recognized, just so that people are not getting away with something that could potentially cause them harm without having an oversight. So
the dangerous part with stimulants too that aren't regulated, even some that are, people will oftentimes, as you mentioned, Melanie, they go from being depressed to maybe focally manic, and sometimes people who think they just have major depressive disorder, they do something, whether it's a placebo or something like a stimulant, or in general, they all of a sudden become more manic and more productive. And then they start thinking that, oh, this is how normal people feel. This must be, I've heard so many patients on Adderall, this must be how normal people feel. I'm getting things done. They're doing their homework while brushing their teeth and doing the floors. It's like, no, there's a level in between where you were in bed and what you are now. That's where it comes in. So I think that's the dangerous part with stimulants.
Yeah. And, speaking the way, you guys can't see, but the way he's moving his hands, it reminds me, like, the endocannabinoid system is all about balance. It's all about how much energy goes where, the immune system, the appetite, the metabolism of your energy. I just said that. So it's amazing to see that with a lot of these conditions, typically we're treating the symptoms for a lot of the stuff. For migraines, we just give a triptan and hope it goes away. If it doesn't, repeat the dose in an hour. Whereas, we do try to use preventative measures, but, figuring out the underlying cause might be more effective, especially, a lot of the complaints I hear from patients when they talk about the big pharma and pharmaceutical industry is that, it's just treating symptoms. It's, just another pill for that. Whereas like cannabis is good for like 7 different things.
Yes.
And even then I've had patients report like spiritual things, which I can't quantify. It's very difficult as healthcare professional on the outside to be able to say, oh, that's how you're feeling. That's how your pain is making you feel. And now you feel better. So you're doing amazing work. Any final thoughts?
Eric talked about alcoholism as being, a big danger. I would certainly agree and say alcoholism is probably one of the most dangerous. Alcohol is probably one of the most dangerous drugs out there. People fail to realize that if you do get addicted to alcohol, you could go into delirium tremens and have withdrawal as early as 2 hours after your last drink, and you can surely die. Sometimes alcoholism is, it's acceptable. People kind of laugh about it, the fun drunk kind of at a party where you're seeing more and more young people getting addicted to alcohol and getting into problems. And so certainly, the car crashes and alcohol-related violence, is so prevalent. Whereas, medical cannabis, no one ever becomes violent with cannabis, even illicit cannabis. When I was young, a movie came out, Reefer Madness. I don't know if any of you saw that. You take one puff of a marijuana stick and you want to beat someone to death with a golf club. Absolutely ridiculousness. But it's really alcohol, the legal stuff, that's really the most dangerous, and not cannabis.
Sugar.
Yes,
Don't even get me
sugar.
started.
Yeah.
Well, thank you so much. I'm going to end the recording here and do it right.